Welcome everybody. So today we're going to talk about hemodynamics and shock and everything that you kind of need to know and the mindset that I typically have when I deal with a patient when it comes to shock and really understanding the volume status of a patient. Okay, so let's start off with this. Say I give you a patient who's coming in hypotensive, feeling dizzy, feeling really weak, and you check the patient's blood pressure and the blood pressure is low. By definition, what defines shock?
Non-responsive to fluids requiring pressors.
Non-responsive to fluid requiring pressors. But if somebody's blood pressure is low, sure, if there's non-responding to fluids requiring pressure, that's a good definition, sure.
Hemodynamic instability.
So what is your blood pressure? What defines shock in the
Less
sense
than-
of blood pressure numbers?
Less than 90 systolic.
Yes. So number one, you can say is a systolic blood pressure less than 90. That's one very definition of shock. Okay, great. What else?
MAP less than 65.
Good. MAP less than 65 is also shock. Okay, what else?
Reflex tachycardia.
Not really. Because you can have a reflex tachycardia if somebody was on a drug like hydralazine, which is going to cause vasodilation and as a result tachycardia, right?
Organ dysfunction.
Yes, so if somebody's got end organ damage, okay, meaning if somebody's blood pressure and your systolic blood pressure is really not less than 90, say it's high, but the patient is typically hypertensive, but it is low from his baseline, but technically doesn't fall into the definition of shock, but you have evidence of end organ damage. What are the classic end organ damages we look for? Which one?
Altered mental status.
Okay, altered mental status because you have decreased blood flow to the brain, sure.
Creatinine.
Okay, the big one is creatinine elevation, right? Elevated creatinine causing an acute kidney injury. That's your classic to look for when somebody is having end organ damage. What else? Troponin. Cardiologists love this one, right? Elevated troponin. Then they love to come and say, hey, this is demand ischemia. Always the demand ischemia word actually comes in. But what they're implying is, when there's low blood flow through the coronary vessels, you are having less blood flow to the cardiac myocardium, and as a result, you're going to end up having elevated troponin, right? So elevated troponin is an important sign too. What else? Yes, lactic acidosis is another important one. Now, why do you get lactic acidosis?
Anaerobic.
So, end of the day,
Cellular metabolism not oxygen, what's it called?
so cellular metabolism
Anaerobic.
is not oxygenated, you're saying is anaerobic glycolysis. Anytime any cell needs to produce energy, you need to go through aerobic glycolysis and then go through a TCA cycle and electron transport chain to produce ATP. But if you don't have oxygen or you don't have enough blood pressure and therefore the cell is not requiring or getting enough oxygen, then you will do anaerobic glycolysis. If you do anaerobic glycolysis, you will produce lactic acid. That's why every single patient you see who's in shock, you'll see lactic acid is actually elevated. So those are your end organ damages. What is number 4? A systolic blood pressure drop by more than 40 millimeters of mercury is another definition for shock. My most favorite definition of shock is what? It is cellular level hypoxia. If every cell in your body does not get oxygen, for me, that is shock because your cell is not getting oxygen. So really what you're talking about, cellular level hypoxia. If you think this explains shock the best, your treatment to fix this will solve all problems. So that's the important reason I like to think of cellular level hypoxia, meaning a cell in your body is not getting oxygen. So do whatever it takes to ensure that that cell gets that oxygen it needs. So these are your classic definitions of shock. Fine. So if somebody is coming in with shock, what is the first important thing that you want to do? Patient is obviously in shock and blood pressure is low. What do you want to do?
Fluids.
Fluids. So really, you said fluids, you said pressors. Which is the right answer?
Fluids first.
What if somebody's got CHF exacerbation and they're completely fluid overloaded, but they're also in shock? See, this is when you go into this confusion state. It's very important when you see somebody and they're hypotensive for you to determine if this patient is in a specific type of shock. So it's very important for you to clinically define what the type of shock is. It's not that we always blindly want to give everybody fluids. Fluid is not always going to be your answer, right? But acutely, if somebody's blood pressure is dropping, it's like 40/20, yes, it seems like you want to give fluids. But really, if you don't understand what the main pathology is, the fluid is not going to solve the problem. Yes, it's going to bring your blood pressure up and buy some time, but it might not solve your problem. So what are the types of shock we have? So let's put it like this. This is the heart right here, okay? And this is your left ventricle, and it's going to pump blood out your aorta, right? Okay, so you see, when you see a patient with shock, it could be a bunch of different things. Most of the time, the ones we typically like to learn about is septic shock. Pancreatitis we see a lot, so we need to know about that one. Anaphylactic shock, not so much. Neurogenic shock, not so much. Cardiogenic shock, yes. Hypovolemic shock, yes. Obstructive shock such as PE, cardiac tamponade, pneumothorax, yes. Bottom line, most patients who are in shock, it makes sense that they are most likely going to get fluid. Say the one that we classically like to see is septic shock or a pancreatitis patient with a distributed shock. Most of the time, the right answer when it comes to somebody in shock is going to be, in fact, fluids. What is one time you can think about where you don't want to give fluids, but rather you go depressors first? Yes, if somebody's got heart failure, congestive heart failure, and they're in shock because they're in cardiogenic shock, meaning your heart is not pumping hard enough, therefore your cardiac output is low. You look at them, they got bilateral pulmonary effusions, congestion everywhere, they got JVD, they got edema all the way, and the patient is in shock, sure, but the patient is fluid overloaded, so you giving them more fluid is only going to work the heart even more. So for a patient like that, you'd rather go with a pressor first as opposed to give volume, and that's going to lead to an increased heart rate. So an increased heart rate to me is a sign that the patient is volume depleted. That's why I'm having increased heart rate, okay? So imagine a patient who's in shock. Let's just walk through this normal process that happens. This is how you want to think about it in the sense of physics, because once you understand it well. So if somebody is hypotensive, you're going to get sympathetic stimulation, and the sympathetic stimulation is going to do what? It's going to cause increased contractility to your heart. If you increase contractility of your heart, would you increase cardiac output?
In shock?
Yes. Say if somebody is in shock, you're like, okay, blood pressure is low, so I'm going to get my beta receptors to fire. Beta receptors are going to fire sympathetic. Sympathetic is going to stimulate your heart, stimulate your beta 1. So you're going to get increased heart rate, increased inotropy, cardiac output should go up. Cardiac output goes up. What happens to systolic blood pressure? Goes up. It has to go up. Great. At the same time, the same sympathetic is also going to go stimulate your RAS system because you have decreased blood flow. And even having less blood flow to the kidney is going to stimulate your RAS system. If you activate your RAS system, aldosterone is going to reabsorb sodium and water. So you're going to increase preload and again bring more volume in, which is again going to contribute to increased systolic blood pressure. And then what's going to happen to your diastolic blood pressure?
Increase because of the...
Because you're going to have resistance and it's going to increase. But imagine if a patient had septic shock. When you think of septic shock, is it the infection that's causing the problem normally?
It's the cytokines.
It's your body's response to the infection. So the infection comes and infects you. Your macrophages are going to eat the bacteria and release all the cytokines and interleukins, which is going to cause a profound vasodilation. So when it causes a profound vasodilation, what's going to happen to diastolic blood pressure? It's going to drop. So it's going to drop, and as a result, you're going to see a wide pulse pressure. So it depends on the type of shock. But typically having a wide pulse pressure, it most of the time is going to be more indicative of a distributive type of shock. Maybe a pancreatitis patient or a septic shock patient. Or even a patient who's hypovolemic, even though you're getting a sympathetic surge and you're going to stimulate your peripheral receptors, which is going to cause vasoconstriction, what happens if you squeeze an empty tank? Can you produce a blood pressure? You can squeeze your blood vessel all you want. But if you don't have enough volume, because you're dehydrated or you lost blood, is your blood pressure going to go up? No, so your diastolic blood pressure will go down. If you look at total peripheral resistance, what is that equal to? Viscosity times length divided by radius to the power 4. It's your total peripheral resistance calculation of a blood vessel. So when your radius goes down because you're squeezing it, your TPR should go up. But when you squeeze a tank that's empty, it's not going to produce that blood pressure. So it makes sense why when you have a hypovolemic patient or a shock patient because of distributive, you would expect a diastolic blood pressure to be low. Another thing, I said viscosity. Viscosity is important to maintain blood pressure. So if you have less blood, it's less viscous too. So as a result, that is another important factor to play a role. And so having a wide pulse pressure gives me some important insights to tell me the patient is volume depleted. What else? What else can you see on the patient itself? Anything else on the patient? What if the patient's got an elevated JVD? If the patient's got an elevated JVD tells me more CHF. So understanding volume status apart from a good physical exam, heart rate being high, blood pressure being low, a wide pulse pressure tells me yes, the patient is most likely hypovolemic. So we finish the physical exam. Say we open the patient's chart.